Well, welcome to the Mental Health Action Partnership. We're going to get started in about 2 minutes. So if you, in the meantime, if you would be kind enough to rename your tile, hovering over the right top corner of your photo, and there are 3 little dots. If you click on those 3 little dots, scroll down, one of the options is rename. Just tell us your place, and if it's appropriate, your organization in addition to your name, and anything else you feel led to share. Okay, Kathy, I think we can get started.
Well, good morning, everyone. And thank you to Sita for always doing such a great job just getting us going first thing in the morning, getting us all oriented into this space and how we can best share with one another. So welcome to the Mental Health Action Partnership. As Sita said, I'm Kathy Markland. I'm the Executive Director with the Wisconsin Association of Family and Children's Agencies, or WAFCA. And I serve on the MHAP core group. For those of you that have been engaged with us, we kind of have a sense of our structure. And so part of that core group helping to keep things driving forward. Thank you so much for making time to be with us today for one of our quarterly summit convenings. We're going to start with a really quick icebreaker. As I contemplated this, I was thinking about the cold weather. And so my question to you, some of us get energized by the cold weather and want to get outdoors and do our activities. And some of us want to just kind of stay indoors and sit by the fireplace. So my question to you is whether you are a ski or a snuggle. So pick a ski or a snuggle. It doesn't mean you literally ski. Could be that you're a hike or a huddle would be another way to put that. So you can be both. And I see that some people jumped in on that right away. People who don't ask permission, I love it. Yes. Thank you, Kathy Colley. That's exactly the order that I was thinking of. Get outside, get active, and then get warm with a hot toddy. That's a good plan. All right. I am impressed by the number of course, we're in Wisconsin. I expect some of you to be people who get activated by the weather. That's right. Just get me out there. That's wonderful. So thank you all for sharing on that, and just the part of the joy of our gathering here is really creating relationship and starting to get to know one another. So just little good insights about each other as we move forward, and looking forward to some time more deeply in groups today having some discussion. So again, thank you for sharing. I'm going to walk through the agenda very briefly this morning, but before we jump in, just a few words about how we participate in today's meeting. It's a virtual meeting, but we are about action. We hope you will actively weigh in from your perspective, either aloud or in the chat throughout the day, because we'd like you to think about how our priorities will affect you and your organization, and what you can do to help advance these priorities. We really want to help you get to action, because it is acting, as we all are acting independently, we're also acting collectively to best move things forward. So in addition to talking about how these policies might positively affect your work or your life, we also want you to think about what's missing, what we're not seeing, and who else needs to be at the table. We're always looking to see who else we should be welcoming into this space. We just want to review quickly the principles of engagement of MHAP. Again, part of this, because we're all coming from different perspectives, and that's part of the power of the collective. So we always ask that before we speak in this space, to please consider, is it true? Is it kind? And will it move us forward? And then we also just generally, as principles of engagement, have adopted these, which have served us well as we've been coming together. So we will seek shared understanding. We will share information and perspectives. Differences of opinion are expected and part of MHAP work, and they're opportunities to learn. We agree that from where we sit, we are each doing what we think is best and fair. When we advocate for system change, consider why something exists and what is needed for improvement. When we disagree, explore further. And as we seek understanding, solutions will emerge. And I have found that to be very true in my work with all of you over this past 2 years or more that the core group has been convening. So let me talk a little bit about the agenda today. Again, just to get us set in our space and kind of ground us as we plan to spend the next few hours together here. We're going to move next to really talking and reviewing the MHAP aim and our indicators and our role as MHAP. Where do we fit? Where do you fit? We're going to go through some work group reports. So that for those of you that have joined us in this space before, this is a common structure that we've been using. We know that we've broken into these work groups. So we'll start with data, move to criminal justice and workforce. We'll have a brief break and then return back to Medicaid and access and equity. We keep growing the work groups. This is more than we had to report out when we gathered in October. And so that's a good thing that we're finding places to plug people in to continue to add their expertise. After we break, after those reports, we'll move into strategy sessions, and we're going to spend some time in breakouts together. So we'll invite everybody to select either Medicaid, workforce, or criminal justice to do a little deeper dive and to do some sharing around kind of what do you really need to help to move these some of these initiatives forward? How do these talking points help you? What are we going to do collectively? And what else do you need to know? And then we'll go to whole group report outs and have some more generalized discussions. So coming out of those work groups, we'll have taken notes and shared and kind of collected those ideas and synthesized that out for people. And then we will move to announcements and some evaluation time, as always, because we're always looking for your feedback on how we're doing. So I have more details about each of the groups, but let's I'm going to move it on to a quick note about work groups that I should share. If you haven't engaged in a work group yet, we're still eager for your participation. So we really think the breakouts will be a great chance for you to get practice today and get some exposure to what those work groups do and how they work. We just invite that continued participation because it's getting us to deeper learning. From here, I'm going to turn it over to Mary Kay to cover some recent strategic visioning work that the core group has been doing. Mary Kay?
Great. Thank you so much, Kathy. I'm Mary Kay Battaglia. I'm the executive director from NAMI, Wisconsin, and I am a member of the core group. The Mental Health Action Partner, which is we call MHAP, and we'll just use that term the rest of the day, is an evolving coalition. We have, as a governance work group, created a vision and identified objectives earlier this year. However, we are seeking the ability to find funds to support our administrative capacity to sustain us so that we can be here for the long haul. So we engaged a consultant, Paul Schmitz, who is a national expert on coalition building, who lives in Milwaukee and works with the Collective Impact Forum. And with Paul's help, we've added some pieces to help us focus on how we can better define our work and making positive changes for people in our communities, and also look at how we can measure that impact, because when you do things, you want to have measurable impacts, and that was missing from our original documents. So I'm just going to briefly go through what we added. MHAP's purpose has not changed. It's still the Wisconsin's Mental Health Action Partnership. MHAP is a broad, sustainable coalition that aspires toward equitable access, continuous improvement, and the integrated mental health care throughout the state. However, what we did add to clarify the aim of our coalition is that we added this lighter green statement of every person in Wisconsin who wants or needs mental health care will be able to easily access quality, affordable care in the community. And the reason we added this is to make it more succinct and more clear. of an aim, and also to add some, in a minute, we'll briefly go over, it makes it more easy to measure, make measurements, quantitative measurements. The objectives of really have no change: to preserve and increase access to prevention, early intervention, and continuum of evidence-based integrated care within the mental health system throughout the state. Ensure choice in care for all with mental health needs that is peer-driven, family-driven, culturally informed, and recovery-focused. And sustain, grow, diversify, better utilize the workforce to meet the demand and provide services for all within the mental health needs throughout the state. And maintain a compassionate, safe, high quality, and accountable system of integrated mental health care. We want a lot in our objectives, and we deserve them. So that's all great. So this is some of the areas of that we have added is how can we measure these results? And some of the things that we identified of things that we could measure include decrease in incarceration and crisis intervention, mental and behavioral health issues. If we can measure both of those, we feel like we've accomplished part of our objectives. Increase in evidence-based services, community-based mental health services, wait times reduced, increased affordability, and address racial and other disparities in access of care. And what do we mean by quality care? Defining that is evidence-based, care that is culturally relevant, care that protects the dignity and autonomy of the individual, and that recovery as defined by people with lived experience. And through all of this, the commonness of it, the role of MHAP, how we feel our role is that we host a common table to advance the system changes that improve access, quality, equity, relevance, and affordability of mental health services and supports. And I can't say how much that is important, the ability to gather so many people together to have this conversation. So I'm going to stop my slides right now just for a minute and ask if anyone has any feedback, questions, thoughts on these new aims and measurable goals that we've identified.
Mark, go ahead.
Yeah, has there been any discussion about having the goal of decreasing suicide in the state?
That is excellent suggestion. That's why we're here.
Okay.
Okay, everybody, any other fabulous suggestions?
Yes, Tanya.
I was just reflecting on the lowering the suicides in the state. I know there is some work that's being done in with the Zero Suicide Initiative. So I would want to check in on that and make sure that if there's work that's being done in this area, it could be expanded on. How widespread that Zero Suicide Initiative is, I'm unsure. And
also inviting them to participate with us. Right.
And there are some Suicide Coalition members engaged in MHAP, and I believe that they have their own coalition, like the local suicide prevention coalitions get together on a statewide basis, and they should be involved in MHAP so that we connect all of these. You know, we're taking down the silos.
Any others? And yes, for everybody, we will send out the slides. Julia, you'll hear her name used several times today as someone to email them. But after this session, this is being recorded, and the slides and other important information will be sent out to everyone after this this summit today. So, all right, I believe that I have covered my section. So who am I going to second? Sorry, I have three things going on here.
Yeah. I'll take it, Mary Kay.
I'm handing it off to Sita now. Thank you.
Hi, everybody. I'm Sita Deal. I'm the Public Policy Director for NAMI, Wisconsin. So we're going to take some time now to review what the work groups have been doing, emphasizing what's new. Some of these proposals were introduced in May and covered in October. So those we're just going to kind of remind you with basic talking points what they are, because we know that there are new people in the room. But there's the work groups have ongoing work. And so they will be presenting new things that they're working on for your for discussion, because that's what we do. We talk amongst ourselves. So the first report is from our newest work group, and I'm going to hand it over to Dr. Rick Imler to tell us about the data work group. Rick, where are you?
Good morning, everyone. I'm Rick Imler. I'm an adult and child psychiatrist up in Woodruff. Thank you for being here. Let me just get my notes here. Our group is very new. I would say shortly after delivery, having been a general practitioner. So, but we begun to define objectives, and consistent with the strategic planning, one of the significant needs is to have measurable goals. And there's so much data out there. Question is, how can it be used effectively? So our first project are to identify the needs for the work groups to support the proposals that you'll be hearing about again today. Also, more broadly, to develop an inventory or library of the existing data that would support improvement in our mental health system. In that process, although there's a lot of data, and in my opinion, not optimally always utilized, to identify where there are clear gaps and also opportunities for accountability. There's a lot of funds that go into the system, and sometimes in unfortunate ways, corrections and child welfare issues. So how can our resources be used most effectively? And then to identify and engage data experts, because this is an area where some sophistication and knowledge of where the data is kept, how can it be accessed, how is it used now, how can it be, how can advocacy really better use that information and share it. I'd like to put in a plug in terms of our work group since we're so new. If there's an interest, please approach us, particularly Sita and Julia, keepers of our email list, if you're interested in joining future meetings.
So anything else that, so now we'll hand it over to Sunny Snyder, who is the facilitator of the criminal justice work group. Sunny.
Hi there, Sunny Schneider. I am a CIT coordinator and I work for the City of Waukesha Police Department as a patrol officer there. So this work group, we're really looking to identify strategies and policies to help with diversion, right? How do we keep people out of the criminal justice system and get them the mental health services that they desperately need? So we already had 2 proposals that we shared last time. We're going to go over a little bit later on, but first we wanted to present 2 new ones that we want to go over. So the first one is going to be the independent ombudsman. So Jim, would you mind talking about that for us?
Jim, please unmute.
I'm so sorry. Usually. Anyway, the Independent Ombudsman Program is this idea that came out in response to the intersection between other disabilities and mental health as a disability itself. The Americans with Disability Act under Sections 2 actually totally deals with jails and prisons and how governments are supposed to deal with folks. And we have very much lived experience, and we have 6,000 persons incarcerated in Wisconsin out of the 21,000 that have significant mental illness. And what we have seen lately, especially here where I am at Waupun, we've had 4 suicides, and we've had a number of actions in which I see that if persons have these coexisting conditions, especially literacy issues, if you can't read, you can't write, you can't fill out the forms to get the help that you need, participate in programming, and just, in other words, move throughout the system with ease, and you don't get the services that you need. In 2000, just this year, Department of Corrections signed a consent decree to deal with actions dealing with persons that are deaf under the ADA. But way back in 2009, Department of Corrections signed another consent decree with Department of Justice dealing with mental health issues at Techeetah. It seems from my perspective that, let's just say, the Department of Corrections doesn't get it when it comes to providing information and the services and accommodations necessary. So we need to put in place someone independent that will hold the department accountable for providing the supports and the accommodations necessary for coexisting conditions. And we think that this policy does it. We also worked with what was her name? Kit, an attorney from Disability Rights Wisconsin, and they are very much on board with this also. So I'm not going to read everything line to line. You folks can obviously do that. If there's any questions, I'd be happy to take them.
Bruce, I see your hand up. Would you go ahead and unmute? Yep.
Sure. A couple of things in reading over the suggestions. I think that you need to also look at training and adding things in for agents, field agents, probation and parole. Probation and parole actually is usually the entry point for everybody going into the system. If there's going to be a pre-sentence investigation written, it's going to be done by an agent who's outside of the actual prison system. And I'm speaking here as a 20-year veteran of DOC before I retired. And every region has a psychologist assigned to it. So there's regional psychologists in all of the probation and parole areas. You mentioned that there's 8 regions in the document, but you didn't identify that those are linked to DCC as opposed to DAI. And when you talk about DOC, it's very easy to just focus on DAI and forget about DCC, which contains a lot more people and affects a whole lot more people.
Yeah, I think you're absolutely right on under line 2 there. We can add probation, parole, staff, psychologists, and agents, or yeah, you can just put that in there. My understanding of it on policy is DOC includes both DAI and DCC, but yeah, many people just look at it that way. And matter of fact, the numbers that I use were just for incarcerated individuals, so you have a very good point. You'd have to double those numbers because we have 21,200 people incarcerated, and there's another 25,000 on probation and parole. You're right.
Thank you so much, Bruce. Mark, I see you have your hand up.
Yeah, couple of things I just want to mention. That perhaps the criminal justice group will look at both qualifications of staff who work in the system and adequacy of staff. And decades ago, all the probation parole officers were required to be social workers who presumably would be able to really help people from their background. And now that was eliminated, so I don't know what the qualifications are that they have. Also, the issues you've identified in the prisons of people with disabilities not getting their services, that's something that a good social worker, caseworker should be identifying. And one of the things, the question is it that there aren't enough staff there, the staff are not qualified, or they just don't know? I do think the ombudsman obviously is a great idea, but I just wanted to suggest that perhaps in the process of the committee, really look at, is there adequacy of staff that can identify the needs of people in the prison system? And I'm also wondering about the qualifications of the probation parole officers in terms of helping people who are in that, in that pathway.
Thank you, Mark. We appreciate that.
You have a huge point. Staffing is unbelievable. And right at the moment, at Waupun, we only have 3 out of 9 positions of social workers just in this institution. And that's something that I think is probably a much bigger issue about having providers and trained staff across the whole state for anything you could talk about.
Matthew, your hand's next.
Peter, thank you. And this is not really a comment or thoughts on the substance of the proposal, but more so a question. And I'm thinking back to Mary Kay's discussion earlier of the importance of this as a big open round table, really explore all of these together and collaboratively. Has DOC been involved in the discussions on this proposal, or just the issues overall?
Zita, we actually had that discussion, and there are plans to bring in some people from that. If you want to talk about that, Zita.
Yeah, we've been talking with Secretary Hoy and Sarah Cooper and Melissa Roberts from DOC, the leadership of DOC. We kind of wanted to get this fleshed out amongst ourselves and then take it to them, but that's definitely the next step.
I mean, I think that's always a good point, though, as we're trying to develop ideas. Do we push forward ideas without, out of this group without having those direct conversations with the folks that the policy is directly impacting? So again,
it's a little bit chicken or the egg. I mean, we've got to kind of bring something to them that makes sense. But then when we've got something that makes sense, then we bring it to them.
Any last thoughts on for Jim on the proposal? Bruce.
Just to add a little bit of background, typically the DOC requirement for people to be field agents and probation parole agents is a bachelor's degree. Typically now it's in criminal justice. It can also be an associate's degree in criminal justice. So that's the big educational background, and it has definitely been a swing away from social work, and it's a different orientation altogether than the social work one. I wish that it remained a social work requirement, but it hasn't, and part of that is cost. The other thing is that DOC right now has been decimated by staffing shortages, and it starts at the guard level, the correctional officer level. Some of the staffing is down over 50%. And you can't run an institution that way. If this is a direct decline result from Act 10 of many years ago, and it's really resulted in that. And until you have adequate correctional officer staff, you can't have adequate treatment within the department. So it's really a big issue. And the legislature has been essentially telling the workers in DOC, tough luck, you're not earning enough money, that's your problem, we're not going to give you anything. And it's only when it's become an incredible crisis that they've actually increased the salary somewhat in the past year or so, but they still have retention problems. And I mean, there's a whole lot of reasons for that, but I'll let it go at that.
Yeah, if I could just speak to that, because I also sit on the Equity, Inclusion, and Diversity Committee, and we are working on retention issues for the state of Wisconsin. And one of what's happening is that we're having to get more people, they're lowering the requirements for the jobs. And as an educator, it's quite frustrating to me to see that jobs that used to have a bachelor's or a associate's degree even are now not at that level, or even masters or above. They're changing. Treatment specialists are being used instead of social workers, and they don't have the same qualifications. Some of them are very good, like Cherie that sits on this group. She works as a treatment specialist sometimes, but yeah, it's quite the quandary. Providers holistically are really hard to get.
Ms. Wilson, I see your hand up there.
Hi, everybody. Good morning. Sorry I'm late. I was actually teaching group. So I wanted to touch on what Mr. Erdman said. I was an agent. I've been with the DOC for 5 years. I was an agent when I entered the DOC. I did not have to have a bachelor's degree. Of course, if you want to promote, typically it is encouraged to have a bachelor's degree. Like if you want to be a field supervisor for DCC, but essentially in order to be a guard, you just have to have a high school diploma. And I think that's always been, but to be an agent, you no longer have to have a 4-year degree. I do agree with Mr. Erdman when he says that we do need adequate staffing, because staffing is what propels our institution. It's what helps us run like a well-oiled machine. However, with the lack of providers, I feel like people with disabilities are really being swept underneath the rug and omitted, because they do not know how to advocate for themselves. And oftentimes when they try to advocate for themselves, it's not to the right person, or they don't know what to say in order to be heard. And so that's why we kind of came up with this ombudsman proposal, because we wanted someone that could speak the language of the providers and say, hey, this person has a disability in this way, but they are having a hard time advocating for themselves. So this person is kind of like a go-between, but also someone that can help educate them on their rights, to let them know what they are entitled to, and also to help them learn how to advocate for themselves. I am a sergeant here at Racine Correctional Institution. I also sit on the NAMI board, and I am the lead and I'm the lead for the policy review EIAC subcommittee, and then I'm the co-lead for the big EIAC committee. A lot, I know. So I listed my resume only to say that I'm really invested in, really passionate about this. I work with people every day where they're just like, oh, I can't, my social worker won't, or I can't get in touch with my agent, or I don't know what to do. And so I just kind of guide them in the right path to get what they need. So I really do feel like this proposal is needed.
Yeah, and before I go to Mary, just reminding the group, we know the DOC has a lot of big issues, but we want to just really stay focused on our proposals that we're putting forward, because otherwise we could talk for probably 100 years. Miss Mary, you're next.
Thank you, Sunny. I just wanted to address a couple of things that I know, to your point, Sunny, I'll keep it short. NAMI Wisconsin has been receiving a lot more emails about people in jails and prisons from families unable to access care. We have been meeting with the DOC about training of staff in something we call CIP, which is crisis intervention training for and I do think that's a part of it, is because there's a lack of training on mental illness and other, obviously this is specifically not just for mental illness, but for, disabilities as well. But I think all of these things are good points. I think there's a lot of problem, but we have talked to the DOC several times from our organization about our concerns and issues. And I think we've talked about having a navigator to help. This is more of that approach and a broader approach. So I think this is a great idea.
Great. You guys are awesome. Thank you so much for the feedback on that. I think we're going to transition to Ms. Sita, talking about 5115. If you want to take it over.
Sure. So everybody agrees that certainly within MHAP, there's broad agreement that the emergency detention process is flawed. But even amongst ourselves in our criminal justice work group, there's disagreement about how it needs to be changed. So we were originally going to propose emergency detention initiators who are clinicians who can place the hold in addition to law enforcement, so that when the situation does not require a law enforcement, like there's not imminent safety risk, when the situation doesn't require law enforcement to place the hold, that a clinician can do the evaluation and place the hold. However, there's a lot of devil in those details, and so what we have backed off to, but just because this is a really this is a big hairball. So what we have backed off to is we would like the Department of Health Services to do a study because there are a number of factors that complicate the issue. The first is that holding a person against their will is a major decision, and it's rightfully driven by a lot of due process considerations. And then secondly, though, lengthy medical clearance increases the probability that a person will eventually refuse care, because there you are sitting in the emergency room for hours and hours. You might have come in, gone, okay, I need help. And then after 6 hours, like, nope, I'm over this. This is excruciating. I'm going to leave. And then at that point, if you meet commitment criteria of imminent danger to self or others, you may get placed on an emergency hold. So then also crisis teams are responsible for the emergency detention decision because the liability rests with the county, but observations of emergency room clinicians who have been with the person for hours, they may not agree. And so who gets to make that decision is a question. And then everyone agrees that narrowing the role of law enforcement would reduce trauma, but the state emergency detention statute requires that the person be taken into legal custody, necessitating a law enforcement role. So, what about that? And then if an involuntary hold is placed, the person must have secure accompaniment to wherever it is they're going, and that's usually by law enforcement or a third-party transport. But if there is third-party transport, then the county has to pay. And so that runs up the bill, and counties are trying to reduce costs. However, the third-party transport may be felt as more humane by the person who is being transported. So what we want to do is ask the Department of Health Services to conduct a study similar to the study that they have done on crisis services recently, where they get people on the ground from all over the state who do this kind of thing every day, and then connect them with the people who make decisions at the state level. And the study should include a comparison of Wisconsin's procedures with those of other states, because we're one of 2 states that relies solely on law enforcement to place this 72-hour emergency detention hold. And then examination of procedural variation between counties, because if you're in one county, one thing happens. If you're in another county, another thing happens. Even though everybody's following the statute, there's a lot of room for interpretation. And then a literature review on psychiatric emergency detention and civil commitment. So what is known out there from research, from evidence? And we're hoping that this study will include a task force. We'll have engaged a task force that includes law enforcement officers, emergency room clinicians who are experienced in the emergency detention process, county crisis team clinicians, county court counsel, police chiefs, sheriffs, individuals with lived experience, and family members, with a special emphasis on diverse communities, because we know that people from marginalized populations feel this most acutely. And the task force members should be drawn from urban, suburban, and rural and tribal communities around the state. So that's the proposal. I'll open it up for questions.
Is there a slide for this we could get for folks?
Oh yeah, Mary Kay, can you put up the slide? Yeah, that's great.
Apologies.
So any questions or comments on this? John?
Yeah, the County Human Service Association, we've been involved in lots of conversations about this topic, and just I'll share some thoughts. You know, as mentioned, Wisconsin's one of only 2 states that limit who can initiate emergency detention to law enforcement, and they are have kind of a heavy role in that. And there is broad interest in trying to expand who can initiate, but as Sita mentions, there's many steps in the process that step to kind of detain or hold the person so that they can be kind of evaluated, and medical clearance can be determined if or conducted, so that if they are taken to a behavioral health hospital, that they've cleared that medical kind of screen. There is the 5115 requires that the county be Human Service Department be contacted and approve the emergency detention. You have to arrange the transportation, and then whoever initiates that also has to testify at the court hearing to the reasons why the emergency detention was necessary. And just the concern that we have is, broadening who can initiate it without really determining how those expanded group of professionals will make sure that all the rest of the steps get done is just a concern. So, having the Department of Health Services, study it and maybe make some recommendations on, how things could be expanded would be helpful. But I know there's been lots of discussions with legislators that there's interest in doing this, but it is a complex issue about how you make sure that all of those steps are completed if somebody else kind of gets the ball rolling.
Completely agree, John. Thank you. It's a very complex process. We need to make sure that we don't have unintended consequences. Would anybody else like to ask questions or speak to this? Matthew?
Hang on, I'm pressing buttons here. I share I actually share most of the thoughts from John too, at WICSA, around some of the complexity, and again, some of the interrelations too with the overall mental health system we have in Wisconsin, and who pays for what. There's so many different intertwined pieces. And that comprehensive look of how we all do this, I think, makes a lot of sense. Given we've got so many folks around this table. We don't have everybody, but we have a lot. I am wondering if this proposal would make sense to maybe expand or narrow down some of the lists of things we specifically want to touch on. And I think DHS, if that makes sense, if they want to do this, would appreciate that too, of what are the very specific issues that we all as a group would find useful to try and help identify what are solutions, all of those things. And I think we got a little bit of it started there, but maybe that's a good role of this whole group, to really pull all the questions together and start to try and sift and narrow what are the most important ones that we really need to figure out to help drive how to untangle some of the messes and how to improve the overall system. Because I think, as John said, it's not like this is a new issue. Through my whole career, we've been talking about this, and it's because there's so many entangled pieces, and part of that was, should we encourage a broader, study that happened 10 years ago, and I don't think got into all of the details to try and untangle some of this. So I think maybe my initial thought and feedback on where this is at right now is, do we actually get a little more specific and pull from all the expertise and trying to make that more specific?
Thanks, Matthew. We'll be in conversation with DHS, whether to narrow it down or, how to shape this in order to move it forward. But that's a very good point, just how do we actually move this forward? Bruce?
And this is another intersection point with law enforcement being involved in the 51 process. One of the things that I think law enforcement will always be weighing is the time commitment needed to dedicate to the process of 51, when the easier alternative is to arrest somebody, put them in the jail, and then hopefully get the consultant in the jail to look at them. And then if there's questions about the whether they're capable of standing trial, they can send them off to Mendota for free to get some kind of a treatment to competency, and then the case can be dismissed later. I mean, that's a track that was followed many times while I was in community corrections. But you have to compare your 51 process to the arrest process and the demands on law enforcement, because if you're short-staffed or there's some kind of emergency, somebody is not going to get a 51. They're going to get arrested because law enforcement doesn't have the resources to dedicate to the process.
Yep, absolutely. This is a criminalization issue. Jessica, I'm going to take up to Brad, and then we got to move on because we don't want to. We want to move through the process. Jessica, go ahead.
Maybe for
go ahead. Let's start with Jessica.
Oh, I'm sorry.
Yeah. Jessica, you're on. We can't hear you. Okay, I'm going to move to Jaleesa.
My comments are coming from the place I used to be a crisis professional. So I was a part of doing these kind of crisis assessments and initiating 5115s or facilitating voluntary admissions to psychiatric hospitals. I definitely am agreeing with a lot of what was already said, so I won't parrot that, but just something else to consider. What I'm thinking about is safety, especially with when you're initiating a 5115. If the transportation is not going to be law enforcement, what are the safety measures taken for whoever's doing that transportation? A lot of the time that medical transportations are voluntary services, and the individuals who are doing those transportations aren't necessarily trained to be able to support someone who is not willingly going with you. I do agree that a lot of the times law enforcement doesn't really help the case when you're trying to get someone to come into the hospital involuntarily. But at the same time, sometimes we are dealing with people who are, the most severe of the severely mentally ill, which can look like violence, right? I've seen law enforcement get assaulted by individuals who are going through mental health crisis. Crisis professionals get assaulted. Hospital staff get assaulted. This overall happens rarely, but it does happen. So I would just say those are some of the considerations we also have to have when we're thinking about how do we make this the safest for everyone, the person who is being detained, but also the people who are working in the system to get them safely transported to inpatient care.
Yeah, absolutely. So secure transport is absolutely. Thank you so much, Jaleesa. Brad,
can
go
you hear
ahead.
me now?
Oh, yes, we can. Go ahead, Jessica. So it's echoing.
I am so sorry.
No worries. Still having technical difficulties here.
Can you hear me now? Can you hear me?
go ahead. Yeah.
Okay, I'm so sorry. I just wanted to speak to this. You know, I've been on the committee to try to kind of get this changed. You know, I think we need all entities at the table. I saw the slide that you guys had up earlier. I really would hope that that would include emergency room social workers. I know that physicians are great, but they don't necessarily know the intricacies of this. The people, boots on the ground, know the intricacies of it. I also wanted to say to Cheryl, I think that's a fantastic idea. I think we need to bring forth the big issues and the fact that really no county in Wisconsin does this the same way before we approach DHS. So I think we need to lay out the issues, which I mean, I absolutely have done, so I'm more than happy to do, but there's a lot of stuff that goes into this, and one issue being the people that are funding this are the people making the decisions, and that's
Yes.
not great.
So we'll
so
work
I'd
with
love to
DHS.
see.
We will work with we'll work in partnership with DHS. It's not a
Gotcha.
before or after, it's a partnership. But we
Gotcha.
kind of have to move on. Brad,
Yep,
can you
go ahead. You're good.
succinctly say what you need to say, and then
Just why are people ending up in ED situations? That data is missing in this conversation, and it's a lot more inexpensive, cost-effective to provide preventative services than to figure all this out.
Absolutely.
When somebody's on the way. Yep.
Yep. Thank you. Yeah, a point well taken. And MHAP focuses on prevention. So yes, thank you. Sunny, I'm going to turn it back to you to just do talking points, and then we really need to move on to our next
If
work
I
group.
could add one point, I'm sorry, I don't want to.
Go ahead, Ken. Yeah.
I do want to say that this is a really rocky frontier between law and treatment. And I think that if you don't get involved in involving the legal reality of it, and not just from the law enforcement angle, but from what people's rights are, you'll end up with something that's not going to work because of the Constitution.
Point well taken. Yeah.
DHS is not a major player in this. I mean, saying we're going to do this, and then we're going to go to DHS. DHS is a secondary player in the process of emergency detention. It's the law enforcement, the public defender.
So Kit, I'm so sorry. We're going to talk about these in our individual work groups. So we're going to be able to do that. Unfortunately, we need to still keep moving.
Waiting for DHS is not, you're going to find out you didn't get anywhere.
We're asking them to do the study. We're also asking them to pull together the key players. Yeah.
Okay.
Thank you.
Yes. And we're going to talk in our individual groups and get that down for sure. So moving on. I need to hit slide 10. Can we get that on the screen, please? And then I'm just going to be going through this really quick because last time we all got together, we had talked about these two proposals. So this should just hopefully be mostly review. The first one is going to be the proposal for a model MOU for crisis response. So the main issue is simply this. People will go in, they'll be in contact with a hospital, whatever hospital that is, and right away, those employees will call for law enforcement for a 5115 assessment, but most places in Wisconsin, officers cannot approve a 5115. You need a crisis county clinician in order to do that. So how do we create an MOU to reroute hospital staff to call crisis directly in situations where people are not actively trying to leave or combative, but they're calm and they're there? How do we reroute it basically and let crisis determine whether or not police need to respond for a formal assessment because that they might be doing a 5115. So MOU in short is how do we just build better relations with our partners and streamline rather than have to redo everything 50,000 times and repeat and re-traumatize the person in crisis. Next slide. Then the other proposal that we had that we just want to review is the TAD expansion. So this is mental health diversion programs, treatment courts to address the intersection of mental health issues and the criminal justice system. provide a framework for treatment, rehabilitation and diversion, reducing recidivism, and promoting public safety. So a lot of regions don't have access to this. So that's one of those things we want to see improved. The request is to expand the TAD statute to target population individuals with mental illness, and that counties should be using the framework such as sequential intercept model to assess the potential target population, identify local services, and determine appropriate diversion programs. So this, we're not going to take questions on right now because we've already seen it, but in our individual groups, we're going to talk more. So Miss Emily, I'm going to turn it over to you.
Okay, thank you so much. So for folks who don't know me, I'm Emily Coddington. I'm the Associate Director with WAFCA. I do serve on the core group, and then I facilitate the workforce work group, which is tasked with addressing the mental health provider shortage. We have two near-term proposals for you today, one on qualified treatment trainees and one on peer support services. These proposals were linked in that email reminder that you got just yesterday or the day before. So you can find the full paper there. But I am going to go quickly turn this over to Ben and Nicole, who actually authored the paper, so that they can cover these materials. And then I will provide a couple of other updates after they share and receive questions. Ben does have to hop off the line, so he will do what he's able here, and then Nicole will fill in.
Hi, everyone. I'll jump in just really quickly. I'll give my best elevator speech on the Qualified Treatment Trainee QTT program. I did tell Emily, feel free to keep any questions you might have for me regarding the program. I work with City on the program administration, so happy to answer any questions. I'll be back at 11, so feel free to send me any questions, or I'll catch up with people in the chat as I'm able to. But the Qualified Treatment Trainee QTT Grants Program is a statewide grant initiative that started in 2020. So we are currently on our fifth fiscal year this year. We're in fiscal year 2025 right now in the state fiscal year. And what this grant program really seeks to accomplish is expanding the behavioral health workforce and investing in clinical supervisors around the state that support those postgraduate QTT positions. So that's referring to those postgraduate master's level social workers, counselors, marriage and family therapists that are completing those supervised clinical hours to reach advanced clinical licensure. The goal of the financial support of the grant, they are our main program, I guess, starting there, is the Expanding Agency Award, which is a $20,000 grant to agencies that hire and supervise these QTTs. So it's actually distributed to community mental health providers, health federally qualified healthcare systems that might hire and supervise these QTTs completing their graduate experience, and support them in that clinical supervision. These agencies, which I'm sure Nicole will be able to speak to really well, do kind of incur cost and time of supervision to complete all those additional supervisory tasks. So that's really the gap that the grants kind of seeks to fill. And we also do a lot of professional development work on best practices in clinical supervision, as well with clinical supervisors around the state while they're participating in the program. So Nicole, I'll be hopping off soon here, but Nicole is actually from an agency that has received QTT grants. So, and she's prepared a lot of great information that's in the issue paper on the costs that agencies incur and things like that. So I'm sure once I hop off, Nicole will be able to speak to that really well. But just a few things from the paper that you'll see just in regards to the issue, and why the behavioral health force does need to be so invested in. These are certainly priority areas of the program, is that, we do seek to address those, health provider shortage areas and mental health providers. 40 of our 72 counties are, have some sort of provider shortage. And, lots of agencies see high wait times, and certainly the trainees themselves, and expanding just the total number of qualified clinicians in the state are goals that we hope to achieve with investing in the behavioral health workforce. So I will pause there because I need to run to my other meeting, but I'll let Nicole pick it up from here. I'm sure she will have a lot of great information for you all. Again, if you have any questions that about the program that can't be answered, I will be back later on and be able to catch up with anyone if they have questions.
Thanks, Ben. Hi, everyone. Nicole Wright from Journey Mental Health Center. As Ben shared, we were an awardee of the grant, and we really used that funding to be able to offset the total cost of, well, not the total cost, but some of the costs as it relates to supervision, and really being able to oversee the interns and then also the qualified treatment trainees as they're earning their licensure hours. Often, many times, as many of you may know that's on this call, that supervision of clinical staff takes a lot of time, and often it's not reimbursable, meaning we're not able to bill for that time we're spending with the staff member as it relates to supporting them, maybe talking about evidence-based treatment, different modalities, and really training them on the therapeutic process. And so oftentimes the agencies and organizations are absorbing the cost of the supervisor, the manager, the supervisor, the team leader, whomever is really providing that support. They are covering the cost of those services, and as you can tell in the paper, it can be quite expensive depending on the size of your organization. Of course, can be an impact on that. Wow, we are Journey Mental Health Center here in Madison, Wisconsin, and so we're a robust organization. We have lots of different services that we offer, so we understand that some of those costs might be higher than a smaller organization that might be in a different part of the state. So really our ask is to continue to fund these QTTs to really help offset the cost of these supervisory costs that these agencies are incurring, that they're not getting reimbursed for. As you can see from the information here, they were cut substantially due to ARPA funding. So we're really advocating that we find the funding to support these grants, to really invest in the future, particularly of those in our behavioral health workforce. We know there's a huge shortage, and this really allows us to continue to have those trainees, those interns coming in, those staff who are earning the hours, post their master's program, to really equip them with the skills and the training to meet the needs of our consumers and our communities that are living within our organization, our communities, across the state.
Thank you. That was super helpful, both Ben's high level and kind of your real life experience. So I want to open it up for questions to see what folks' thoughts are about this particular paper. Mark?
Yeah, I've been on the advisory committee since the beginning, and I know a lot of agencies, or a number of agencies, that have benefited. The issue we're trying to address, as Ben mentions, is there's huge disparities in workforce in various parts of the state, particularly in rural communities, communities of color, diverse communities. We've heard some groups have as much as a 6-month waiting list. I just talked to a clinic in Appleton that is a diverse clinic. They speak both Spanish and Hmong, and they also specialize working with LGBTQ clients. And as soon as they have a waiting list, and they just hired some folks who are going for their 3,000 hours. Their schedules are filled immediately.
Mm-hmm.
So the point of this, one of the points of this program is you're giving money to agencies in these, let's say, rural parts of the state where there's very few providers. They have huge waiting lists. You have people that go out there and work there. Hopefully they stay there. So you're adding providers to that part of the state. So this is a really important program. And as mentioned, so we started out the first year, and the program funded about half or so. We had a base level funding about half of the qualified programs. And then Governor Evers used ARPA COVID-19 monies, and we're able to fund all the programs that qualified. This year, it was a huge drop off. We had like 111 applicants. We funded 12 or 13. And if you look at the map, when we had the additional funding, we're able to fund programs every region of the state, and also serving diverse communities. And now we're just able to fund like 12. So
yeah, right when we need it most, right, Mark?
Yeah, it's an extremely important
Yeah.
program to meet the mental health needs in the state, particularly in underserved regions of the state and underserved populations for whom English may be their second language or other underserved groups. So it's an extremely important program.
I agree.
Thank you,
And it
Mark.
sounds like Mark is going to be one of our core advocates. So that's amazing. Kit.
Yeah, one thing I'd like to advocate for adding as a sub piece of this is when you think of foreign language, you know, other languages, you think of Hmong and Spanish and whatever else. But there's a real problem of providers who can directly communicate with people who are deaf or hard of hearing that sign. And one of the big obstacles to that is that they are unable to get their hours, the 3,000 hours that they need to get their certifications and qualify, because the cost of interpreters, which isn't for all 3,000 hours necessarily, but the cost of the ASL interpreter that needs to be there so the mentor or whatever that person is called, I'm sorry, I don't know the title, that supervises person, supervisor, usually is not deaf, does not sign. And so there's no way for them to get that supervision and oversight. And there needs to be some funding added that would allow for interpreters to be paid so that this could happen.
Yeah, that's a great point and definitely aligns with one of the objectives of the work group, which is to make sure that we have culturally and linguistically appropriate services. So thank you for raising that. Okay, to keep us on track, I'm going to move us on to our next proposal as I don't see any other hands. So thank you so much, Nicole. Nicole will be present later also for a breakout room if people are interested. Okay, and so I'm going to ask for Nora to join me to talk about our peer support paper. Nora was instrumental in bringing this work forward to our work group, and then built this paper in partnership with Zay, who unfortunately is ill. She's also a member of the core group. So she won't be able to present today, but my hope is that Nora is on the line and available to take over.
I don't see Nora. If you're available, Nora, please unmute yourself and talk.
I hadn't scrolled through to see if Nora was here. So
yeah.
Okay, well, this looks like it's going to be very brief. I will present essentially the conversation has circled around making sure that we are broadening the scope of who can provide services and recognizing the importance of the individuals with lived experience who are certified as peer specialists in our state. Currently in Wisconsin, we can reimburse peer services, specifically peer support services. There are a variety of different kinds of peer services through CCS, but the person has to enroll in CCS, and there are often long wait times and documentation requirements. So it's pretty cumbersome. There's also delays in that reimbursement, which imposes pretty significant financial hardship on small peer-led organizations. Some peer support is available outside of CCS, but it's severely limited by a lack of grant funding. And then to develop the peer support workforce, we really need to increase training and fund organizational readiness training and technical assistance, in addition to facilitating career advancement amongst peer support professionals. So the ask here is really to create a billing code that would allow Medicaid reimbursement for certified peer specialists directly, then help us kind of overcome those barriers to both the documentation requirements, which are they'll still be heavy, right? If you can get Medicaid reimbursement for that. But the wait time for reimbursement should be less. And if there's anyone else who has been closely connected to this paper and the work that's been done on it, please feel free to chime in. Otherwise, I will take questions that I will take back to Nora and Zay, because I don't know that I can answer them for you.
I do have a question quick. So is this to for people to be able to access peer services across in programs outside of or beyond CCS, or is this to make it a card service? Like anybody with Medicaid insurance can just get access to that service like they could a doctor or a dentist?
I believe it's the latter, and
Okay.
we'll look to those. Okay, I'm seeing nods, yes. And
Yeah,
not
I
that they
think
couldn't still get services through CCS. I think it would be a both. You could get CCS services provided by a certified peer specialist, and also if you had Medicaid, you would be able to access those services. Any other questions? Tanya.
Have we looked to see how the current legislation that's being proposed around peer support is mirroring the recommendations within the paper?
That I do not know. It would be wise if that legislation was viewed as helpful from the peer support community. Sita, I see you unmuted.
Yeah, Tanya, can you share that bill with us? And we'll take a close look at it.
Sure.
Ms. Markland.
Yeah, so I would be curious too, Tanya. I'm wondering if you're referring to the peer recovery rule that's moving through DHS right now, which is providing for reimbursement for peer recovery coaches. And we'll start to move towards a direction of more options for people to be reimbursable in more settings. But it is that rule will not apply to peer specialists per se, as I understand it right now. But I agree, it'll be helpful for people to have that within the context of the paper so they can know how to navigate those differences because it's pretty nuanced.
Leanne.
So I was just going to share in terms of training, we recently were awarded a grant to help expand parent peer support services statewide, and the activities in the grant largely revolve around the provision of supplemental training for certified parent peers to help navigate the system differently, to, develop advocacy skills and other things that might be necessary to be effectively employed that isn't necessarily covered in the certification process. In addition to that, there is a large chunk of that grant that will be focused on training employers on how to effectively supervise and support lived experience in the workforce. So there are training efforts that are forthcoming in the parent peer support world, primarily though for youth care, youth systems of care.
That's good for us to know though, because whatever advancements they make there, could be applicable elsewhere. So thank you for raising that. Okay. Before we move into our break, I have a few other things to cover here. So wanted to make sure that I let you know, Ben, who was presenting on QTT, works for CITY, which is the Center for Inclusive Transition, Education, and Employment at UW-Milwaukee. And we had previously put forward a proposal regarding a compensation study, and decided that MHAP itself would not have the capacity to do that. And I'm happy to report that City has stepped forward and said that they will take on that work. They have some limited capacity to do advocacy work with a capital A. So doing some of this data gathering and looking at compensation is something that they felt like they would be able to carry for the group. And it's actually a really big lift. So we really appreciate that. And then I have a couple of different talking points that came forward out of the recommendations from our last summit. If we can pull up that slide, that would be lovely. Okay, so last time we presented on the State Healthcare Provider Loan Assistance Program. And from that beautiful issue paper that Rochelle prepared for us, we have pulled these talking points, which really help define kind of both the issue and our request. So these programs, the Healthcare Provider Loan Assistance Program and the Rural Physician Loan Assistance Program, already exist in statute, but they are not applicable to behavioral health professionals. So the request is really that we add those behavioral health professionals as eligible providers in both programs. in accordance with allowable federal program requirements. So federal law allows it, but our state law does not currently, have these professionals included. We're also asking for an increase in the maximum award amounts for eligible professionals to incentivize that program even more, which will obviously require an increased investment in funding using state GPR and increased program administration funding for the Wisconsin Office of Rural Health. So those are the talking points that are existing for that particular paper. I don't know, am I taking questions on these or are we just moving through them? I think we're just moving through them.
We're just moving through them, understanding that we're cutting into our break if we take questions.
Okay, fantastic. So then I have one more, which pertains to the community support program. The community support program is a set of psychosocial rehabilitation services for persons who live with serious mental illness. And it is based on the evidence-based assertive community treatment model that was developed here in Wisconsin. So right now, CSP is covered under the medical assistance program and can be administered by counties and tribes. And it also uses a multidisciplinary team approach for serving clients in the community. The problem is that counties currently have to pay the non-federal Medicaid share, which can be pretty substantial, and it does result in access disparities between counties and reduce incentives to align with the ACT model. Any evidence-based practice that you're lifting certainly has a cost associated with it. So the request here is to transfer the non-federal Medicaid financial responsibility from the state or to the state from the counties and tribes. We also want to enhance Medicaid reimbursement and staff training for CSP programs progressing toward ACT fidelity. We want to, sorry, I'm seeing chats pop up here. Allow for regional cooperative agreements to staff hard to fill positions, particularly related to psychiatry and AODA specialists. And last but not least, we would like to incentivize CSPs to provide first episode psychosis programs by offering the coordinated specialty array of services to youth with emerging psychosis. So this would be a great preventative measure if we can get early care to young people. We have much more success in treating their mental health long-term. Okay, with that, we're just a couple minutes behind schedule. I'm going to go ahead and transition us to break. I'm still going to ask that we come back by 10:30 so that we can make sure that we have time to get to the other proposals. And if you can do me a favor, and when you come back from break, just make sure you turn on your camera so that we know everybody's back. That would be great. So we'll see you in 13 minutes.
All right, I've got 10:30 and I think I'm up, Sita. So I'm just going to go ahead and get rolling here. Welcome back, everybody. Hope you had a good break and were able to step away from looking at the screens for just a minute to rest your eyes. We're going to move on to the Medicaid work group report. And I think ours is probably going to be among the most brief. We do not have new proposals to bring forward to you today. These are things that we're revisiting from our October and prior presentations. Just a reminder that the Medicaid work group is really charged with thinking about how Medicaid is used to deliver mental health services. We know how critical it is within our healthcare infrastructure, what a critical role Medicaid plays to support mental health services. So we're talking about things like reimbursement rates, regulations, billing requirements, and having good conversations within the context of our work group. You've already heard about a couple Medicaid related items. I think you'll see it threaded through many of the other work group activities. Two of them, CSP and peer specialists, just presented just before the break. They were shared issues that the workforce committee ran with. And so we have three things that are on our list today, and ongoing work that will be happening, and really invite you all to join us in the Medicaid work group. But let's start out with, so the three items are psychiatric residential treatment facilities, dialectical behavior therapy, and clubhouses. We'll go over some of the key talking points of these three issues again, which were presented at our time together in October in more depth. So very briefly, a psychiatric residential treatment facility, or PRTF, is a non-hospital facility that offers intensive inpatient services to children and youth under the age of 21, and it is Medicaid reimbursable. PRTFs are not currently an available setting in Wisconsin. So children who need that level of care are often going out of state to facilities that are PRTF licensed. So supporting children in state through PRTF would provide for better transitions. We can all well imagine that being able to have children closer to home improves opportunities for family and school engagement, and really start to utilize that higher level of treatment and intensity that is available through PRTF to move children more smoothly up and down the continuum of care as their mental health needs change. It would divert children from settings that are not equipped to serve mental health needs, such as detention or emergency rooms and shelters. So we really see this as an increased opportunity, a different setting to be able to be more responsive to children's needs. So the ask is to pass legislation to authorize the Wisconsin Department of Health Services to create PRTF certification, and then ultimately to provide GPR funding to establish services and sustain ongoing operations, along with Medicaid rates to cover the cost of care. And ideally, again, in these settings, commercial insurance also stepping in to be a payer for these services, as these are treatment settings, not placement settings for our children. So that's the main ask. And at this session, we're really looking for that legislation to authorize DHS to move towards certification. They just need to be empowered to do that. It will require some ongoing funding, but that will come in subsequent sessions once we have the authorization. Next slide. Dialectical behavior therapy, DBT. This has been a really active group that has been working towards moving forward with a DBT targeted benefit to better serve our folks with mental illness. So DBT is an evidence-based practice that has been shown to be effective in treating a range of problems associated with impulsive emotional behavior and substance use that increase the risk of suicide. Comprehensive DBT requires 5 components, and so you can see those 5 components listed here. Only comprehensive DBT with all 5 parts reaches the intended outcome. So here we're really looking to move to a system that would support comprehensive and DBT more to fidelity than our current systems allow for. As is noted here, state Medicaid requires providers to bill using disparate outpatient codes, which leaves gaps in the DBT service array. And state regulations are inadequate to really support comprehensive DBT, which leads to less positive outcomes for people who are served. So the request is to create an intensive Medicaid mental health outpatient treatment benefit for individuals at chronic or marked risk of suicide, either adequate reimbursement for individual and group treatment, coaching and consultation groups, or a bundled Medicaid rate that includes all 5 components of DBT and adequately covers cost. So really it would be either approach to creating an appropriate reimbursement to meet the needs of all of the 5 elements of the DBT model. And then our additional proposal is around Clubhouse, again, another evidence-based, community-based mental health program that empowers people with mental illness to take control of their recovery and thrive through access to employment, socialization, education, skill development, housing, and improved wellness. The daily activity of the Clubhouse is organized around a work order day where members and staff work side by side as colleagues to operate the Clubhouse. 23 states have amended their state Medicaid plans to include this benefit that clearly defines and accurately reimburses Clubhouse services. So the requests are really to enact legislation and appropriate funds for matching grants to Clubhouse programs. Bills were introduced in the last 2 sessions but didn't pass. So again, this would be supportive funding that would be essentially undergirding foundational funding for these Clubhouse programs. And then also one of the challenges that has been really well articulated in our work in our work group has been the question of reimbursement through CCS under DHS 36. So the request is to amend 36 to allow for accurately reporting best practice milieu-based Clubhouse programming. And in simplified terms, I will just say that Clubhouse, it's a heavy lift for how they currently have to document and track within the Clubhouse system to be able to get that 36 reimbursement. So really looking to make that more in alignment with how they operate and to better serve and be responsive to the people who are supported in Clubhouse. And then implement a state Medicaid option based on the Clubhouse Medicaid benefit implemented successfully in Michigan. We love it when people come with good examples from other states of how this can be operationalized. And really, Michigan has become the model that our Clubhouse folks have really elevated for us, is the way that we want to move. One of the things that I'm excited about within what's happening within our Medicaid space right now is that we really are referring to sort of that deep end when we think about PRTF, and that where we need some support for facility-based responses, but then also really addressing those community-based and those peer-run and peer-led models. So I think we're capturing evidence, we're capturing community-based services, and we're addressing gaps in the continuum through these 3 proposals and really elevating that need. So I'm happy to take questions or comments you have about these 3 proposals. We'll be able to talk more about them in the Medicaid breakout work group as well, but would accept anything that people want to weigh in on, or even anybody who's involved in them. If they want to provide more context, we have space for that. I had a feeling that ours were going to be well kind of vetted at this point. So good work for our Medicaid work group, and I'm going to take the balance of the time then and kick it back over to Sita.
Thanks, Kathy. So I'm just going to talk about the access and equity work group. The charge of this work group, we want to include and empower partners from diverse communities around the state. So the access and equity work group is kind of fundamental to what MHAP does, because we're creating a community, bringing forward the voices that are often less heard in the conversation and around the table. We also want to identify issues and solutions to meet the mental health needs of diverse populations throughout Wisconsin, and there is ample evidence to support that we're not doing a great job on this. So MHAP wants to raise up practices that will help bridge from people's kitchen tables to mental health services that they need, and ensure that those services are culturally responsive and fit the frame of their culture to the extent that it's possible. So I'm going to briefly cover the talking points for the access and equity group proposal that was presented last October in the summit. And then I'll go into detail on an outreach and engagement strategy that we've been working on, and we invite the work group members to weigh in. So we've already talked about community health workers. We were very fortunate to have some community health workers at our in-person meeting in Wausau, who talked about their work respectively with the Latin and Hmong communities. We also had community health workers. We were really fortunate to have Ingrid Rivera from the Milwaukee Area Health Education Center, who does the actual training for community health workers statewide. She came to our summit in Milwaukee. But this is what CHWs are, and I'll invite other folks to, actually, I think I'm not going to invite other folks to weigh in, but you can discuss this in the breakout groups that we have. But community health workers are public health workers who are trusted members of the communities they serve. So through outreach, community education, informal counseling, social support, and advocacy, CHWs facilitate access to services and improve quality and cultural responsiveness of service delivery. CHWs are embedded in diverse communities. They live in the communities that they serve, and they have a demonstrated ability to identify and engage people experiencing mental health challenges, understanding that mental health and mental illness are framed very differently across cultures. And then they can facilitate access to care, improve outcomes, and yet current CHW services are limited. Right now, much of the CHW work that goes on is grant funded. There are a lot of folks who volunteer. There's some going on within the CCS program, but we need better Medicaid reimbursement for CHWs because they provide a bridge to mental health services from communities that are grossly underserved in Wisconsin. So our request is to create a billing code to allow for Medicaid reimbursement of CHW services that fall under the federal authority for coverage of prevention activities. This really is prevention and early intervention. We were talking earlier about narrowing the funnel into the criminal justice system and trying to divert people into services. CHWs really help with that. And then our second request is to enhance mental health and substance use training and continuing education to strengthen the CHW capacity to recognize signs of mental health challenges and support clients as they engage in professional mental health services. So we want to include additional mental health and substance use components in the Milwaukee Area Health Education Center, or AHEC, virtual training for CHWs. And Milwaukee AHEC has been doing this for a while, but then during the pandemic, we had a silver lining moment where the University of Wisconsin helped them put the training online in a very sophisticated, engaging way. So we want to lift up that training and emphasize mental health and substance use training in there. So I'm asking you to think, I think we will take a few moments for this discussion here. I'm asking you to think in an integrated way about community health workers and how their work relates to yours. And when we're advocating for this proposal, it's important to talk about how CHWs add value to mental health care, even if your organization doesn't currently work closely with them. So let's have the discussion just for a few minutes. I see Mark's hand raised already. Who already works with CHWs? What has your experience been for the value that they bring and the need to strengthen their work? And how can you, whether you work with CHWs now or not, how can you work collaboratively with CHWs to build bridges for people from diverse backgrounds who need mental health services? And I'm going to call on Mark.
Yeah, I wanted some more explanation about the second request. I mean, I think we have to recognize the important role that all people in different positions in organizations play. I mean, I'm familiar with a licensed clinical social worker who works at a community health center in Milwaukee. And so I think we have to be careful about what the role that community health center person is playing. It seemed to me to be like a referral identification, but they wouldn't be doing therapy. And that's something and they shouldn't be called a mental health provider, but so the second, it was a little unclear what the second request was. I mean, it's fantastic to have the training and to integrate them in the operations. At the same time, if you're looking to provide provide adequate services to our BIPOC communities that speak different languages, different backgrounds, not only do you need the community health center workers to identify and refer them, but you need the folks who can actually provide the trauma-informed services. So that also needs to be a part of we're looking of any kind of plan that we have if we're looking to expand services. I just want to kind of give that context. I mean, community health centers, I've worked with them in different capacities my entire career, making referrals and stuff, but I just want to make sure that we understand the differences and who can do what, and that we don't leave sight that we also need the mental health providers as well as the folks who are seeing clients initially and can identify and make the referrals.
Absolutely. Excellent point, Marks. I'm wondering whether Ingrid or Harvey, who are on with us today, would like to weigh in.
Yeah, I'd be more than happy to. Good morning, everybody. I'm Harvey Paddock with Milwaukee AHEC, and I'm the director of CHW operations there. Our CHWs, as they go through the training, they are not provided any sort of skill level to provide services. You are correct, Mark. However, they are mostly working with individuals to help them navigate the process, understand who to contact, how the process works, and help them go through that and feel comfortable and confident in doing so. And basically what they're trained to do. They are trained to do, as Sita mentioned, that bridge between services availability and the underserved population that needs it.
Thanks so much, Harvey. Lisa.
So currently in my role, I manage a mental health clinic, and we're a bit unique because I'm at Health First Network, which first started off as a reproductive health clinic, and that's the primary work that they do. The mental health clinic has been the newest addition with, we also have a WIC clinic, and we have a community mental health worker who works as part of our clinic. And I mean, she is an absolutely wonderful addition. Some of what we did to kind of help incorporate her with our mental health group, you know, she completed all of the mental health trainings that all of my staff have to complete. She also is creating a database of all of the resources in the counties that we serve, because we have 10 locations within 9 different counties. She's also she does the mental health screenings for us when we're getting new clients. So done some training with her on kind of like, what are the questions you should be asking, you know, like what are we, like what's the inclusion exclusion criteria, just because we have very limited services with our clinic because it's fairly new. She helps with when we need interpreters for clients that we have. We also had some refugees who we were serving, who spoke languages like Rohingya. So she was really just really great in helping us figure out like how we either get over the phone or video interpretation to meet the needs of our client. She is Hmong speaking, so we see a lot of Hmong clients, and she is absolutely integral in explaining the process to them and kind of helping them feel more comfortable with seeking our services. As if you work with Hmong community, mental health can be a really touchy subject and isn't always necessarily embraced. And she's also right now working on coming up with another resource pool of Hispanic resources for our Latin community. So I think community mental health workers, I wish we could bill for all of the things that she does because she wears so many hats. So it makes me very happy to see that this is something that we're asking for. I think if you do work with community mental health workers or you're looking to, yeah, like being able to provide them extra training if they don't already have that training and really incorporating them into how you guys are operating. She is a part of our weekly peer meeting. She's also a part of our group supervision. We're really trying to give her the kind of education and the kind of training so that she understands exactly what we do so that she can make appropriate referrals. She makes most of our referrals. So I think really making sure that they have that good understanding of what you do and trying to figure out how you can best utilize their skills and incorporate them with your clinic.
That's fabulous, Delisa. Thank you so much. It's a real illustration of what CHWs do. So I'm going to move on, everybody, but just tuck that into your thinking because this is something that MHAP does. We recognize practices and we lift them up. So I'm going to ask that the slide 23 be put up. I'm going to talk about it briefly about an outreach strategy that we are engaged in the Access and Equity Work Group. So we worked with Ubuntu consultants, thanks to support from the Advancing a Healthier Wisconsin Endowment through the Medical College of Wisconsin. And they worked with Julia and me. Ebony and Corinne worked with Julia and me to assess MHAP strengths and needs related to empowering diverse voices in MHAP. And the result was a set of recommendations that were discussed in the A&E work group. So we're going to pursue 4 strategies, and I'm just going to talk through them briefly now. So we're going to expand communication channels and digital presence because people from diverse communities want to check us out on the internet, understandably. Having been involved in what is called extractive efforts before, they want to check us out and find out how, what we do, how it relates to them and their experience and their work, and how genuine we are. So we're going to develop a website in 2025, and it'll be, I'll talk about that in a second, but we're also going to rely on you all to help us develop a social media presence. So the website will explain who we are, our purpose, our aim and activities, and we want it to include photos and quotes. So we're going to be asking for help from you all on that, just to bring it alive. Like, these are people coming together around Wisconsin, around a common table to share perspectives and priorities and come together to move things forward and lift up practices that may be fabulous, but they're on the periphery right now. People don't know about them. So the second one is to define and communicate clear partnership benefits. People come in, they're wondering, what am I going to get out of this? So the Access and Equity Work Group discussed, and then the Governance Work Group will develop a partner benefit proposal, which will go back to A&E and go, yeah, this speaks to us, or no, you might want to tweak this. We may bring it forward to you all. That's the way MHAP works. So just as an example, a couple of the benefits might include that there is strength in numbers, because we gather large and small organizations and individuals from around the state. So it's an opportunity to come, to learn, to listen, and to share. And to ensure that the right voices are leading the discussion on policies that directly affect diverse communities. So our criminal justice discussion was, a really good example of that. It's something that people from diverse communities experience differently than people from the dominant culture. And it's really important to have diverse voices at that table. And then we are initiating a peer-to-peer referral initiative. So we're asking all of you, each and every one of you, to invite diverse partners to MHAP meetings and learning sessions. So our summits, as you can tell, are all business. We clip right along. We also have learning sessions where we lift up something that we, as all of the partners in MHAP, need to know. We hold these monthly on the months that we're not having the summit, and all of the recordings, we have them right now on a shared drive. We'll put them on the website so that we can all learn together. Then we also have work groups, not only the A&E work group, but we need diverse participants in all of the work groups to lift up the voice of the folks who are not being considered by public policy, or not adequately considered by public policy right now. So think about the people you know who may be working in silos and who would benefit from the opportunity to amplify their voice and participate in collective action with the whole mental health community around the state. And then another proposal was we should maybe do listening sessions with BIPOC communities, but the A&E work group verified that this kind of listening session strategy is overused. People are used to going, okay, here comes another one. I've got to give my feedback, blah, 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 blah. So people, instead, what we want to do is participate in meetings where people already gather from BIPOC organizations, the organizations of color, the tribes, whoever is working in that cultural space, to invite us in to listen for mental health needs and identify culturally responsive solutions that people have already developed. So for instance, the tribes have this wonderful family circle. It's very traditional. It was going on for, God knows how many hundreds of years. And it's a really fabulous strategy that we can lift up and showcase. So please think about who needs to know about MHAP and introduce us, specifically Julia and me, to the people who might invite us to those tables. And so members of the work groups will go and just listen and, engage in conversation as it moves forward. And then also there's a lot of information already. As I said, people have been doing listening sessions for a long time, and a lot of that is already gathered in data such as the county Health Department needs assessments and the 2019 GAPS report. So with the help of the data work group, we're going to take a closer look at those needs and potential solutions that we may be able to bring to a wider audience. So I think we're just going to leave this with you, but we would love to have your feedback, your thoughts on this strategy, and there is a role for all of you in this. So I'm going to transition right now to time to act. So we're going to break into work group action strategy groups. There are going to be 3 groups. And it's time to plan our course of action on these priorities. We're going to focus on those priorities that require legislative action, and not all of them do. And we're going to ask you to help by gathering support from your networks and from your local communities. So what we want to do here is build a buzz around these proposals, kind of lift them up and give them momentum as the legislative session begins in January, because if policymakers, county board members, decision makers in local communities as well as at the state go, okay, the mental health community really cares about, this set of proposals. We need to think seriously about them. That's the result that we want. So think about which of these proposals are important for you and your organization specifically, but also those that might indirectly benefit your work or your lives. In MHAP, we're working on breaking down silos. I love to say, it's a little corny. I say, I know we're a farming state, but we got to break down the silos. So we recognize that different parts of the mental health system are interconnected, and we need to work together. So as a reminder, MHAP currently uses an opt-out model for our priorities. That is, if you support a given priority, you can join the effort. And then in January, we're going to start circulating sign-on letters for legislative proposals. We don't require every MHAP member to sign on to a proposal for it to be included in our agenda. That might change as we develop, but this is the model that we're using for now. And we're going to divide into 3 breakout rooms: Medicaid, workforce, and criminal justice. To drill down on strategy, we're going to consider allies and barriers and raising awareness. Members from the data work group and the access and equity work group are going to fan out in the 3 breakout rooms to listen and give feedback from their perspective. And all of you who have, if you've not joined a work group yet, pick one that interests you. This is your chance to see how they move. They really do the real work of MHAP, all of this, really focused stuff that we've been bringing forward. That's the work of the work group. So you can just see how they work and engage and decide, what works for you. We're going to have 45 minutes for the breakout room discussions. You're going to see a menu of choices. Click the one that you want to join. And so Julia is going to open this right now.
So hopefully folks had wonderful engagement, and we had really good conversation in our breakout group. And so we're going to go through a process and have each group report out. So if you guys want to raise your hand to kind of volunteer if your group wants to go first. I'm going to ask for our group, at least, that the note taker report out, because I was not capturing notes as the facilitator. But other groups can make their decision about who's best to report out.
Okay, I was with the work group. We first hit QTT. Was suggested that we talk to counties, hospitals, clinics as allies. We would discuss how important it might be for those that are participating in MHAP to talk to the Joint Finance Committee members. We also talked about one idea is finding out if there's a way to find out the list of all the organizations, clinics, whomever that applied for QTT grants, and find those that received them, and also those that were rejected because they probably want an expansion and continue funding of QTTs. There was discussion about clarifying the QTT for supervisors versus the students reimbursement. And there was some discussion about how difficult it is for the continuation. If you get a QTT funding one year and then you don't get it the next, it's kind of like a disruption of a flow of being able to provide that care within your clinic or hospital or wherever you're being utilizing the QTTs. The second one was talking about the peer specialist. Those that we thought would be great to collaborate on that would be all the peers, drop-in centers, respite centers, certified peer specialists, advocacy groups, independent living centers. The biggest barrier we talked about quite extensively was educating legislators what a peer specialist is, and kind of really outlining graphically talking points on what a peer specialist does, because we live in this world, we're in this bubble, they have no idea what that is. And so we found that to be a strong talking point. Ellie brought up that there's peer recovery conferences, and I know there's lots of conferences coming up. We just opened NAMI's as well, and some of you may know that perhaps having these conversations at these conferences and submitting applications to present these ideas at the conferences is also a really good idea. Then we just started talking about loan program for behavioral health, loan forgiveness program. We talked about schools and private schools and especially professional organizations collaborating with us on that. And really, we identified the biggest barrier to this is funding, as it is for many things. And we were just in the heat of discussing this a little bit further. So that's kind of the notes that I took. And if I missed anything, please, anybody on our group, let me know.
Thank you so much for covering that. I think businesses was the only other, with regard to who may be persuasive in the conversation, particularly as it relates to either, just expanding access for mental health services. Businesses could be important. Okay, so do we have volunteers for another group to go next? And I can't see.
I can participate, I can report from the mental health, from the criminal justice work group. We talked about the two proposals that actually involve the legislature. So that's treatment alternatives and diversion expansion, and then the DOC ombudsman. So with TAD expansion, it was mentioned that this has been brought up a bunch of times in the legislature, and it just never quite makes it across the finish line, but that there is a TAD committee who has been working on this for a very long time. So Kit will introduce us to key people there, just to see if we can get, what I'm thinking is we can get citizen support for this. Maybe it's the usual suspects, and that's why it's, I'm going to add myself as a spotlight. Okay, there. Maybe it's that it has been the usual players, and the legislators are, yeah, you've got vested interest in this, and maybe just by bringing the mental health community in, we can help just push it across the finish line. There were several people that were named who are key people in that, including a relatively newly formed Milwaukee Criminal Justice Council with a lot of heavy hitters, including Chief Judge Ashley, who was the folks from Milwaukee, thankfully, just recently introduced me to him. So we'll go forward with this conversation. And then the Wisconsin Criminal Justice Coordinating Council, and it was made that we really need to bring in prosecutors into this conversation. So that's what we'll do. The barriers seem to be individual legislators. I'm not sure how many of them are still in office, but there have been some that have just taken exception to this. And then there was a definition of who's eligible. It used to be, or there was a violence perspective on this, and sometimes the violence was way back in somebody's history. So we're trying to remove that. We think that the costs have been identified, so we'll know what we're asking for in the budget. And what we need to do is get MHAP groups from the district of the legislators who are raising opposition to talk to them and just engage them on this. The second thing we talked about was the DOC ombudsman proposal. We absolutely have to have DOC support on this, otherwise the whole thing is dead in the water. It has been already mentioned because DOC is being sued over folks with disabilities. So DOC is already moving in this direction, and we may have to ask the governor to add it into his proposal. And if it's too late for that, we'll see if it's in his proposal already, but if it's too late for that, find a legislative champion, preferably one in the majority party. So we're looking for a Republican legislator. We thought about various groups like Wisdom, and then the groups representing ex-incarcerated people who need to be part of this. The Great Lakes Intertribal Council has been doing a lot of work on criminal justice diversion, so engaging them in this as well. And then, let's see, needs to be a bipartisan effort. And if we're going to get this kind of support, we may need to do a sign-on letter sooner rather than later. So maybe this month rather than next month. Sunny, what did I miss, or anybody else?
You nailed it.
Okay, there were some brought up some really good legal arguments, like Title II of the ADA requires that people can participate in public accommodation. And so what this does is it prepares people when they're incarcerated to participate productively in society, bottom line.
Yeah, legal arguments are always helpful. Okay, last but not least, we have the Medicaid work group.
Yeah, I guess I was the note taker, and we sort of had a wide-ranging, open-ended conversation, so I might not have gotten everything in the right categories, but I will tell you what I wrote down. Among our allies would be crisis centers, Human Services Department, Child Protective Services. We're talking about psychiatric residential treatment facilities for this. One of the barriers that was brought up was perhaps the providers. There may not be sufficient providers or providers who would want to be involved in such a facility, but that would be an education opportunity for those providers. Want to be sure that safety concerns would be addressed under education, and also clarify that we would be starting with getting the enabling certification, and funding for various treatment facilities would come down the line, not initially, and that we would focus primarily on the enabling certification first. Also, as a talking point, talking about expenses as it is currently configured in our state, and since we don't have any in-state facility of this sort for children, comparing that with Lincoln Hills, which is only being used 50% of the time, I guess now, or to 50% of the capacity, talking about where are our dollars actually being spent now and how could they be better spent. And there was a suggestion that MHAP could get on the DHS monthly standing crisis calls. Anything I have left out of this, committee members, for this particular one?
That's great.
Okay,
Keep it
keep
up,
going.
Cheryl.
Okay,
Yeah.
DBT, who needs to be involved with this effort? Active clinicians, as well as possibly involving suicide prevention organizations in support of DBT. Barriers, of course, are funding for training. Providers can be trained and can't be employed because there's a lack of funding in the employment area. We need to educate how the DBT can be used through the county services, and an example of that being in Jefferson County, how they were able to utilize that. Need to educate professional organizations, perhaps, about what fidelity means in their providers, and if this were more widely supported, then they would encourage their providers to be educated to fidelity. And some of the talking points is that it can be done through CCS, and that it could be a solution for rural communities. Even though they don't have the patient volume to support it, it could be helpful to them. That use of telehealth could be part of the solution there if they don't have the providers in person. Finally, the third one was psychosocial clubhouse programs. Our allies currently are NAMI chapters, Clubhouse International. There are some legislators that are already on board because they have been talking with the groups. Some of the barriers would be to educate people as to how this is helpful and how it's differentiate this kind of service from other services that are already provided. Some of the problems could be the Medicaid documentation issues, but they could educate on why Medicaid funding would be important. There was a stress on needing braided funding rather than just depending on Medicaid or grants. Again, this could be a strong part of the continuum of care in rural areas. Another talking point was that members who are part of clubhouses want to work and they will try to get back into work, into meaningful work, and this is also a choice. This is what they choose to do. Another aspect of education might be when working with transitional youth, getting them aware of and perhaps into clubhouses. Did I forget there? Anything? 2 and 3?
I thought you nailed it, Cheryl. That was a lot. We had a very, as you said, wide-ranging discussion. So you
Yes,
captured
did.
it
Okay,
beautifully.
thank you.
Thank you.
Yeah, great job, note takers. And thank you for reporting out, because I don't think that was another duty as assigned, I think. So appreciate it. It just made sense when you are facilitating and then you don't have the information in front of you. It's very helpful for the people who jotted those things down to share. So we've had a lot of really good conversation about these proposals. We have the issue papers, we have the talking points, we kind of have this outline now for who we might partner with and what kind of barriers we may face. And while that's not comprehensive, right, everything still needs to be fleshed out there, we want to kind of refocus the group on thinking back to you as an individual or you as your organization. You know, what might be feasible for you to carry these proposals forward between now and our next summit in February. So when we talked about this as the core group, I was like, well, what's realistic between now and February? Because it doesn't feel like there's a whole lot of time, particularly when we think about the holidays that are in the mix. But for WAFCA, as an example, we talked specifically about, okay, well, we could really dig in on these proposals as we prepare for our own WAFCA advocacy agenda and figure out which ones we're including in our budget advocacy, either that we're planning to lead on or that we're going to support on. And we could also educate our members so that they can start to consider what advocacy efforts they may engage in as it pertains to these specific pieces. So that's a couple of examples of how we might carry that work forward. Wanted to open it up, though, for discussion from other agencies about what you see as possibilities for kind of doing that kind of brainstorming within your own organizations between now and our next summit.
Well, I know from NAMI's perspective, we have included, excuse me, several of these. Well, we included a bunch in our survey to our membership. Our legislative priorities come from a survey of our membership. So we included some of them in that survey. And so some of them rose to the top. And so, you know, we will be advocating on those. We've included them in our legislative agenda. It's what we'll be talking with legislators about. And then we're also educating our membership. So we are doing articles in our newsletter, you know, just bringing it up on calls that we have with our local leaders, you know, just doing whatever we can to kind of get the information out into our membership. And then what we're looking at is when the rubber meets the road and the legislature opens in January, we would love to participate with other MHAP members at the district level to go and talk with legislators and or county board members or whoever we need to talk with in order to get these decisions across the finish line.
Chrissy, are you trying to share? Oh, I was gonna say you're muted. Sorry. Kathy.
Yeah, I just wanted to drop in the chat. The governor's having his listening sessions on his budget right now. So to think about like one tangible thing you could do right now is attend the virtual listening session that's coming up on Monday, and share some of this information in that listening session. I'll also drop in the chat. There's a link to just provide for some feedback directly to the governor's office about priorities. So certainly to take some of these talking points and just share them with the governor's office as they're putting the budget together is one tangible thing people can do with this right now.
Very good call to action. Leanne.
So I actually would love to tap you, Emily and Kathy, along these lines as I'm transitioning job roles, but the Youth Behavioral Health Crisis Redesign Charter, which is sort of funded and also led by the mental health, the public-private partnership, right, in Milwaukee. And the PRTF is something that has been very much of a topic of interest for this group, made up of child welfare and youth justice and mental health and the hospital systems. So I think just finding other in terms of actionable items, right, bringing this information to that group for this brainstorming process to be able to understand from other perspectives what else we might be able to add, as well as sort of utilizing that group to bolster advocacy and information to share. So that's just one next step, I guess.
Yeah, that's a really great idea. Lisa.
Hi, this is Lisa Hassenstadt from Disability Rights Wisconsin. I'm just going to ask a big picture question, and you can tell me to take this offline, and that's totally fine. But a lot of the things that have been discussed today have direct or indirect ties to Medicaid. And I think a lot of us are hearing a lot about what might be coming down the pike at the federal level for Medicaid. And I know that I have been in conversations with folks recently about an interest in kind of re-engaging of an advocates group around Medicaid. I know there has been in the past, there's been some folks that have been doing that. Maybe there's something that's already moving forward. I don't know, but just wanted to acknowledge that one, a lot of these things might have more pressure in trying to move them forward because we don't really know what the big picture is going to look like. So I don't want to be doom and gloom, but I think it's important to have that on our radar. But also just wanted to check in, and if folks want to pop in the chat or whatever, if you know of activities that are already happening around kind of collective messaging to folks at the federal level around Medicaid, I would love to hear it. And or if you're interested in being a part of a group that would be doing some messaging on that ASAP, please feel free to let me know. This feels like an all hands on deck moment. And I think my guess is that there's a lot of people that are a part of this conversation that would be interested in helping to move that messaging forward.
I'll just jump in and say, yeah, I love that, Lisa. And can you drop, if you don't mind, putting your contact information in the Zoom, because I do think, how do people actually plug into where those efforts are elevating? I'm aware that there are groups that are forming to get into that defensive space, but let's not just call it that, but to do the Protect Medicaid, right? Like we need to move into certainly thinking about what and being able to share forward. All of these things are great things that Medicaid can do for people in our state. And so really framing it that way, that all of the good things that Medicaid is already doing to support the kind of infrastructure that we need to care for the people who rely on what Medicaid provides for, which is a substantial amount in this state. And so even as we're looking to grow that programming and grow that resource, we need to be aware that there may be different forces that are at play at this point. And so thank you for that.
I think that's also really good to flag, Lisa, because I do think that with other conversations that we've had with legislators, you know, it seems like if they can find an easy way to shut down a proposal, like, oh, we don't know what's going to happen at the federal level, so we're not going to go and have conversation about that. We should be prepared for that. And I could see that being deployed pretty regularly. So for us to be like, yep, we know, and also still, you know, this is why it's important. This is why it's valuable. We can't wait to see what's going to happen. We should take action now. All of those things are helpful. Pete.
Yeah, I've got does MHAP, do we have any type of a, you know, like a bulletin board or something that we can share things that we're doing? And so the group can see what's being done, and then we can connect with others that maybe, hey, they're doing this, you know, doing some of the same stuff we're doing. How do we work together with them? Is there somewhere like, and in some ways, you know, have it be a source of also where we can feel like, you know, we're taking baby steps and getting wins, you know, because we're opening doors. And, you know, so I don't know if that's anything that you guys have thought of or already have that maybe I need to be aware of.
I have two thoughts on that, and I would welcome others from the core group to weigh in. So one is that, I mean, we have been compiling these resources in the Google folder. So I do think that there's a space where we could add additional information from each individual agency. The other piece is that what I will move us into in just a minute relates to kind of our next step, where we're doing information gathering from folks about, okay, let's talk through the items that we've put forward and consider which sign-on letters in particular you or your organization are going to be willing to add your names to. So we're basically going to be sending out a survey listing the sign-on letters that will be available so that individuals and organizations can check the boxes for the ones they're going to be involved with. And we can start talking with decision makers to get those letters kind of moving forward and sharing. I'm guessing that individual organizations, just like WAFCA would, will be putting together their own advocacy materials, borrowing from some of the language that we have created jointly through MHAP. So we will have a way to at least see which organizations are signing up to carry forward which items and in what way they're going to be involved, whether that's a sign up or a sign-on letter, or Mark was sharing in our work group, for example, that he's willing to meet with members of Joint Finance on advancing the QTT proposal. So that is yet to come. But then when we can share things out like that and buddy up with people, in addition to seeing the materials that other people are going to create, I think we'll have a pretty nice repository, so to speak, and an easier way to find partners. Sita?
Well, yes, and yeah, yes, you know, look at the sign-on letters as they come out. But Pete, that's a fabulous idea. So what we'll do is we'll take this back and we'll just think about the technology that exists right now that would create this kind of shared space. You know, the Google Drive is okay for posting stuff, but it wouldn't do. It's not like the bulletin board that you're talking about. So we'll talk about this and we'll just see what we can come up with. It's a fabulous idea.
Okay. Any other questions or comments you have before we transition to announcements? All right. With that, then I will kick it back to you, Sita.
Thanks so much. everybody for this wonderful conversation. I'm just going to spotlight myself here. All right, here I am. And I'm going to ask if we can get the calendar slide up for 2025. We've sketched out a calendar. The word sketch is important here because we just want to make sure that we can get on your calendar. Please mark your calendars for these things. They might shift around a little bit depending on who's available when and what else is happening, but we would like to just make you aware of the MHAP events that are going on over the next year, over 2025.
Did we want to?
Oh yeah, let's talk about communication. Excellent.
Thank you.
Thanks. Yeah, that's great. So when we're carrying forward MHAP things, we need to be able to frame who MHAP is and our relationship to MHAP in kind of a consistent way, because policymakers are going to start going, what is this MHAP thing? So it would be really good if we can be able to say in a way that is at least aligned, if not absolutely consistent, this is who MHAP is, and this is my relationship to MHAP. So the governance work group came up with a few suggestions, just guidance. First of all, the MHAP logo is only used on communications that are generated by the core group. And that's just the way that we can make sure that what we're doing has been blessed by MHAP as a whole. So if there's a communication that's going to come out where you want to sign MHAP on or put MHAP in an active role, communicate with Julia and me, and we'll bring it to the core group. And then only those things that are generated by that are the things that are usually generated through the work groups, but then approved by the core group, will have the MHAP logo on them. But for instance, if you're talking about an MHAP priority, you could say, I've been participating in MHAP, which is a statewide mental health coalition, and through collective insight from other participants, I have learned X. And I or my organization believe that we should move forward with advocating for Y. So if you're looking at one of these proposals, the issue proposals, you might say, I have learned about the lack of access to disability-related services in the prisons and in community corrections, and then I believe that we should move forward with an independent ombudsman to oversee Americans with Disabilities Act compliance in DOC facilities and programs. So that's just an example. Or as an independent participant in the Mental Health Action Partnership, I represent myself. So not everybody here is an organization. Some people are coming as individuals, and even those who are part of organizations, sometimes we're going to come as an individual. We'll wear our individual hat. So as an independent participant in the Mental Health Action Partnership, I represent myself and or my place of business. We have consulted with our partners in MHAP on the subject of X, and based on the collective input from this coalition, it is my organization's recommendation that Y. So for instance, on peer support or QTT in particular, you may say, we've got a real shortage of providers, and we've consulted with our partners at MHAP on how to get people licensed. And so based on the collective input from this organization, it is my organization's recommendation that we move forward with expanding the QTT grant availability. So that's just an example of how the QTT talking point would plug into this. So we do have a Google Drive where we're putting all the papers, and we sent the talking points paper out. We sent the issue papers out in the emails in advance to Julia sent them out. Thank you, Julia, in the invitations. And then these links will also go out in the follow-up information. So if you want to share that follow-up information with people in your networks, go ahead and do so. But we're trying to maintain, the more policymakers can hear the same message repeated over and over and over again, the more they're going, oh, okay, these folks have talked amongst themselves and come to a sense of agreement, and we think it is wise to move forward with this. Anything else I missed about communication, anybody? Or questions about communicating MHAP priorities? Sheree.
I don't have a question about communication, but I do have a question as to if we can get some swag, like hoodies or t-shirts, bags, pens, something.
All right.
Please.
Great idea. We could do pins, I think. Pins are cheap and very, you know, you can put them on anything. We thought we were doing good to plan a website, but I agree with you that it helps to show up with something that has our lovely little green Wisconsin MHAP logo. It's a great idea.
I just figured like by wearing, like being a walking billboard, somebody could possibly say, well, what is the Mental Health Action Partnership? And it could be kind of like a silent call to action. Like,
yeah.
Well, I'm so glad you asked. Got a minute? Let's have a coffee.
Yeah.
We look forward to getting to that point. We're just, again, the whole reason we're trying to clarify our aim and our data collection and everything is so that we can get to that point to afford as a group to do some things like that. But we do, I think, have funding to make some pins, so we'll do that.
Great idea, Sheree. Any other thoughts on MHAP communication before we move forward?
If you really want to make Sheree happy, get some water bottles.
All right, that's additional grant money. Yeah. Okay. Somebody's asking if the MHAP communication slide is available for reference. Yes, it is in the governance document. So it's on this slide, which will be sent out as part of the follow-up from this meeting, but it's also in the MHAP governance document. And I recommend, if you haven't actually looked through it, it is not that long and it's very thoroughly thought through. I mean, the fact that we're able to hold this kind of productive meeting is because the governance work group has done a lot of very deep thinking about what does it take to operate an inclusive and yet effective coalition. Okay, so I'm going to go through our tentative calendar, emphasis on the tentative. So the first learning session, I talked about the learning sessions. Those are virtual learning sessions to which you can invite anybody. You know, folks who won't participate in MHAP but need to know about the topic, or people who might participate in MHAP and just want to get a size of what we do. So this is open to the public, but this will be a learning session. Excuse me, the purpose of the learning sessions is specifically so that MHAP members, which are broad and diverse, can tool up on what we need to know in order to advance public policy priorities and improve the system in Wisconsin, the mental health system in Wisconsin overall. So the first learning session of the year will be tentatively January 24th. All of these learning sessions are held on a Friday from 2:30 to 4. We usually have part of it is presentation, part of it is going into breakout groups, because part of the purpose of MHAP is to just chew on this information with each other and exchange ideas and then report back out. So that learning session will be on the children's system redesign, which has been underway for, I'm not sure how long, but a while. And it's kind of a partnership between Department of Health Services, Department of Children's Services, and Department of Public Instruction. And they're coming up. Maybe I'll throw it to either Kathy or Emily to say a little bit more about the children's system redesign. What would you like to describe it better?
I won't go into deep detail at this point, but I mean, there is a specific proposal around a children's behavioral health initiative that is a piece of sort of thinking more broadly about what it is that we need within our children's behavioral health system to really be more responsive when you think about all of the different places where we have touch on children in our but whether it be at schools or through our other systems of care. So really thinking comprehensively about that, and what introducing people to sort of the thinking around that and how we think about children's system of care more broadly.
Thanks, Kathy. Whether you work with children as part of your organization's work or not, and this is your opportunity to find out, consider joining the learning session on January 24th. February 12th is our next virtual summit, and there we'll just kind of drill down to, by then we'll know who are key legislators on the Joint Finance Committee and on the Mental Health Committees for the Senate and the Assembly and the State House. We may know something on Medicaid at the federal level. I attended a webinar yesterday and I came away with my hair singed. So, so we will do kind of on the ground power mapping and just looking around for who we've got, how we can gather together at the local district level and talk to decision makers. So please plan to join us, even if your organization doesn't do advocacy or can't do advocacy. I know that there are some, like academic institutions that have to be very, very careful. So, but there are plenty of things to do besides actually speaking with decision makers and doing the actual on the ground. There are a lot of roles for everybody. So come, even if you're not engaging in legislative advocacy. Then in March, we'll do a learning session on peer-run services. I'm just delighted with how many people have stepped forward to indicate interest. We want y'all to huddle and come up with what does the MHAP community need to know about peer-run services. So that'll either be March 14th or 21st, depending on who's available when. On April 11th, there's a learning session on catch safety plans, and this is something that it's really great. It's come out of Ashland County, Bayfield, and Iron counties, and up north by Lake Superior, have developed these wonderful plans that don't involve HIPAA private information sharing, but do have the information that's necessary so that when someone's in a crisis, the people who are tending to that person and working with that person can share the information that they need to know, and it hooks in a very sophisticated way into data while protecting public privacy. So you may want to, this is an issue that has been a problem everywhere. And so you may want to listen in on that. This is a very evidence-based practice. May 9th learning session, how to use data to advance public policy priorities. We're hoping the data work group will, kind of shine up their best knowledge and share it with us. June 11th will be an in-person MHAP summit. Haven't decided on the location yet, but that's where the legislative session, the budget will be kind of in the final throes at that point. We'll kind of have a sense of where we're going and what we're dealing with. Then we'll skip July. August, we'll have a learning session. August and September and November, we will have learning sessions on topics to be determined, because we want to remain a finger on the pulse in the environment and raise up learning session topics as they are of interest to the MHAP community. There will be an in-person summit either October 15th or 22nd. Again, location to be determined. We try to be out and about across the state to get away from being Milwaukee and Madison centric, but on the other hand, we want everybody to be able to come. So we're noodling through the locations of where these in-person summits will be, hoping that as many of you as possible can take the time to come. And then there will be a virtual summit, may or may not be a virtual summit in December, but we're putting a place marker here. If we need it, the legislature will be kind of winding down at that point, but there may be other things that we need to attend to. So we have a place marker for a virtual summit in December. So that's it. And I am going to throw it over to Mary Kay to close us out.
All right, I'm going to turn this off, right? So I just want to thank everyone that have done a lot of work in this short of time. You've given us a lot to think about and plan. That's weird that you make me so big.
Sorry.
Somebody want to join? Anyway, complete the priority survey that will come to you from Julia. We will send it out in a follow-up message with these slides as well as the talking points. We are excited to have, to me, the greatest part of this is gathering folks together. If you know of a place that would be great to meet, if you hear of a foundation or a fund that would help continue the administrative support of MHAP, please let us know, and we're always looking for ways to continue to provide the funding to keep us going. And it's not a campaign, it's just we'd love to have a website so we can gather and do things and all that sort of, we want to have those t-shirts and water bottles. Really, that's less important, but I'll get one, Shell Ray, a water bottle when she comes Friday. But anyway, please share about us, talk about us, let people know that we're gathering and we're doing this together. I think it's really important. We mark our 2025 calendars when this comes out, especially the February 12th summit. And please remember to complete that evaluation. It really helps us set these up. You know, it's a lot of work to set these summits up, and we want to be engaging. We want lots of participation. We don't want people to just say, oh, it's another one of those summits, I don't want to go. We want people to be involved and their voices to be heard. So give us the feedback on those surveys. We really appreciate it. So I think we are done. Sita, did I cover everything you wanted me to cover?
Yep, you did, except that I want to point out that Julia has put the summit evaluation, the MHAP priority survey. So that's where you think about what you and or your organization are going to prioritize in your individual advocacy, and then also the evaluation for this meeting. Both of those links are in the chat. So we love you to take a moment to complete those, and particularly start with the summit evaluation. The other one will come out as a follow-up, and you may need to think more deeply about that. But the summit evaluation is quick, and we use it. So I'm just kind of talking here so that you all go ahead and pull it up. And we want as many of you as possible to do the evaluation because we really do use it. We're very data-driven in MHAP, and we also really value your feedback, and we take all of your suggestions into account in our work.
So thank you guys for letting you have 10 minutes to your day. Woo-woo. And have a wonderful holiday. It's snowing here in Madison now, very lightly. And I guess all of you that are skiers and snugglers get to choose what you're going to do today. So enjoy your day. And thank you all for gathering with us.